This is a dictation on patient Pauptit, P-A-U-P-T-I-T, Carol, C-A-R-O-L. Please address it to Dr. Snyder, S-N-Y-D-E-R, initial N, paragraph, date of visit. Date of visit APR2/19, paragraph, DGX, Pianka vasculitis, with history of microscopic Pianka vasculitis, paragraph, vasculitis, including renal insufficiency and hematuria. Stop, treated with IV methylprednisolone, followed by oral prednisone and Rituxan, 2 courses, January 7 and January 21st, 2019. With good response and an improvement in kidney function. Stop. History of recurrent upper respiratory tract infection with no clear evidence of lung involvement. Stop. Thyroid cyst. History of hypothyroidism. And thyroid nodule. Stop. Thoracic aneurysm on CT chest 2016. Stop. Syncope 2014. Shingles of the left eye 2016, paragraph. Current medications, vitamin D 2000 IU per day, calcium and Prolia. Paragraph, interim history. Carol has been followed by a combined nephrology and rheumatology clinic at Mount Sinai. She tolerated Rituxan infusions in January quite well and responded to it in terms of kidney function quite well as well. Her blood work that was done prior to treatment showed negative c-ANCA and negative anti-GBM. She was also negative for RF, anti-CCP, as well as ENA and anti-DS DNA serology. Her all complements, C3, C4, and CH50, were normal. Paragraph, she is experiencing recurrent episodes of left-sided facial flushing and redness over the face and ear. They can be present for several hours and disappear. She was assessed by ENT in the past and her exam was quite normal. Stop and paragraph. Paragraph, impression, Pianka vasculitis with predominant vasculitis with good response to Rituxan. Carol is going to continue treatment under the supervision of combined nephrology and rheumatology service at Sinai. She still would like to follow up with me intermittently. Stop. She was advised to do blood work as advised by by her specialists every 2 to 3 weeks. I told Carol that her her flushing of the face and ear is not typical for vasculitis, and it's possible that she has some form of allergic reaction. This might be also perhaps sequela of VZV infection in 2016. She will try rupatadine 10 milligrams at HS for a month and will keep track on the number of episodes she's experiencing. Stop. I will follow paragraph F/UP OCT/19. Stop. Ferkul, FERKUL. Joseph, JOSEPH. Please address it Dr. Hogan, HOGAN, initial M, and CC Dr. Forrester, FORRESTER. Initial D. Thank you for referring Joseph, who is 56-year-old male with respect to possible psoriatic arthritis. Stop in paragraph. Joseph has psoriasis for close to 10 years and has been on a variety of topical preparations. For the last 3 years, he has been treated with Stelara, which has been very effective in clearing his psoriasis. Stop. He has been experiencing right wrist pain and mild stiffness with no swelling. He seems to have a localized minor swelling, suggestive of ganglion cysts. He also has occasionally shooting pain and numbness in his right arm. Stop. He has otherwise no joint pain, swelling, or stiffness, and no symptoms suggestive of dactylitis or enthesitis. Paragraph. He is a chronic smoker. Paragraph. Meds, Stelara injections. Paragraph. Allergies, none. Paragraph. FHX, no psoriatic arthritis. Paragraph. P/E. Revealed normal general physical exam. MSK exam revealed limited neck extension and lateral bending bilaterally. Peripheral joint examination revealed small localized swelling at the dorsum of right wrist with no clear synovitis. There was also no evidence of dactylitis or enthesitis. Paragraph. Impression. Joseph has psoriasis that's well controlled by Stelara, and at the present time he has no clear evidence of synovitis, dactylitis, or enthesitis to suggest psoriatic arthritis. I think his right wrist pain is related to ganglion cyst. He was referred for x-rays of hands, wrists, and feet and ultrasound of the right wrist, and I will call him with results. He will also complete blood work. Stop. He was provided with information about psoriatic arthritis. Stop. Thank you for referring this patient for consultation on patient Eichenberger, Eichenberger, Kenneth, Kenneth, initial A. Please address it to Dr. Snyder, SNYDER, initial N. Paragraph. Thank you very much for referring Ken, who is pleasant 60-year-old male with respect to severe calf pain. Calf and hamstrings pain. Stop. And paragraph. Ken has been experiencing severe pain in his calves for over a year. He describes as though his legs, particularly his calves, feel as though they are made of, in quotation, wood. He feels stiff in the morning and also as he walks. He has no pain in his knees as such and has no knee swelling. He was seen by a physiatrist who felt that his pain might be related to OA of both knees and that cortisone injection he did improved about 30% afterwards. He had arterial Doppler done, which showed no evidence of PAD, but presence of Baker cysts in right knee. Stop. He's not experiencing any joint swelling. He also has no symptoms suggestive of either vascular or neurogenic claudication. He has type 2 DM and is followed by Dr. Hamid for the last 3 or 4 years. He's experiencing numbness in his feet. His feet also feel as though they are stiff or woody. Stop. He has a history of dyslipidemia as well as atrial fibrillation, and has been treated with Lipitor for the last 3 years. He stopped Lipitor 3 weeks ago, and he is somewhat better without it. He's also experiencing sporadic muscle cramps in the calves, mostly at night. He has no history of psoriasis, IBD, or uveitis. Stop and paragraph. Current medications of Lipitor: atenolol, toloxin, metformin, Jardiance, Pradaxa. Paragraph. Allergies: none. Paragraph. FHX, uncontributory. Paragraph. P/E. BP 122/70, no pedal edema, normal heart sounds, irregular heart rate, lungs clear to auscultation. MSK exam revealed medial joint line tenderness in both knees with no swelling. Calves were tender to palpation. Muscle strength was 5 out of 5, proximally in upper extremities, and 5-/5 in lower. Proximally, he had a limited range of motion in the right hip. Stop and paragraph. Blood work: negative RF and ANA, normal CBC, ESR 1/4, creatinine 73, ALT 24, normal TSH and T4, hemoglobin A1C 6.8. Paragraph. Impression: can presents with stiff hamstrings and legs, an abnormal sensation in his feet, including numbness. He may have diabetic neuropathy, and I referred him for nerve conduction studies to investigate it further. It is also possible that this pain represents side effect of Lipitor, and he was advised to remain off Lipitor for a total of 2 months and start coenzyme Q10, 200 milligrams per day. He will also have ultrasound of both knees to see if there are Baker cysts bilaterally. Lastly, he was referred for additional blood work, and I will contact him in case any relevant abnormalities stop. Otherwise, I will review Ken again at 2 to 3 months. Stop. Fernandez, Fernandes, Domingos, Domingos. Please address it to Dr. Todd. TODD, initial D, and CC Dr. Hannah, HANNA, initial S. Paragraph. Thank you for referring Domingos, who is 43-year-old male, regarding chest pain. Stop and paragraph. Domingos has been followed by you has been seen by you regarding anterior chest pain at the level of second and third sternocostal junction. He also is known to have chronic dry paroxysmal cough since FAB/17. Stop. He is a smoker, on average 10 to 12 cigarettes per day. Stop. He has no history of rashes, including psoriasis, no history of IBD or uveitis. Stop. He has history of reflux, and that's treated with Nexium with good response. Paragraph. Domingos is experiencing pain in his both shoulders as well as over the upper right side of the sternum and at the sternocostal junctions. He is not experiencing any joint swelling. He has usually few minutes of stiffness. He usually has at least 30 minutes of morning stiffness, including shoulders. He has no history of spine pain or stiffness, particularly at night, and there is no history of alternating buttock pain. Stop. He has been taking Tylenol or Advil as needed with no response. Paragraph. He carries antibodies to hepatitis C. Stop. He has a history of gastritis in February of 2015 and has been diagnosed with IBS. Paragraph. Meds, Nexium daily. Paragraph. Allergies, none. Paragraph. FHX, father, brain aneurysm. Paragraph. He works physically for a construction company. Paragraph. P/E BP 123/17, no pedal edema, no rashes and no nail lesions, no thyroid enlargement or lymphadenopathy, normal heart sounds, lungs cleared, auscultation with no crackles or wheezes. MSK exam reveals deformity of right clavicle, likely related to fracture, and tenderness at the right second and third sternocostal joints. Mobility in both shoulders was normal. There was also no obvious synovitis at either SC or AC joints bilaterally. There was no evidence of dactylitis either. Stop and paragraph. A bone scan done in October of 2017 showed uptake at first and second costosternal junction bilaterally, sternomanubrial joint, AC and glenohumeral joints, and also uptake at SI joints. Blood work showed negative ANA, anti-dsDNA, and ENA screen. CT scan of the chest, July /1/7 showed right upper lung calcified granuloma, and chest X-ray was normal. Paragraph. Impression. Domingos presents with pain at the right second and third sternocostal junction. He also has deformity of the clavicle, likely related to injury, and otherwise no evidence of synovitis on physical examination. He was referred for additional X-rays, including shoulders, and sternoclavicular joints and sternum as well as AP pelvis. He will have additional relevant blood work done. I placed him on Celebrex 200 milligrams twice a day to see if that would have any effect on his current symptoms. He was advised to remain on Nexium and take Celebrex with small snack. Side effects were explained. Stop. I will follow up with Fernandez at 3 months time to review in more detail all the results and additional treatment. Stop. Thank you for referring this patient for consultation. Stop on patient Cressman, Cressman, Dominica, Dominica. Please address it to Dr. Holler, Holler, initial T, and CC Dr. Ibrahim, Ibrahim, initial A. Thank you very much for referring Dominica, who is 57-year-old female with respect to possible relapsing polychondritis. She has been experiencing recurrent episodes of redness, pain, and swelling of the right ear with sparing of lobule, as well as some pain at the external ear canal. The pain can be so severe that she would describe it even up to 12 out of 10. She has at least 3 to 4 episodes per month. She has improved with a short course of prednisone. She tried naproxen for about a month and has not responded to that treatment. Her ENT exam, including neck, ears, oral cavity, as well as flexible endoscopy, was normal. She has no history of recurrent infections. There is no history of shortness of breath or chronic cough. She also has no history of valvular problem. She is not experiencing any joint pain, swelling, or stiffness. Stop and paragraph meds, amitriptyline 20 mg at HS and Reactin 1 tablet daily. Paragraph allergies, codeine. Paragraph she is non-smoker. She works she works at OTMH in housekeeping department. Paragraph FHX uncontributory from rheumatological perspective. Paragraph P/E BP 127/70 no pedal edema, normal heart sounds, lungs clear to auscultation. MSK exam reveals no evidence of tender or swollen joints. Ear exam in particular was normal today. Stop and paragraph impression. Dominica likely has relapsing polychondritis. I explained condition to her and suggested she try Celebrex 200 milligrams once a day for a couple of months and see whether her episodes would become less frequent and less intense or disappear altogether. If Celebrex won't be helpful, I will change her to Dapsone. She was referred for additional blood work as well as echocardiogram. I will review Dominica in June. Thank you for referring this patient for consultation on patient Waddell, Waddell, Casey, Kasey. Please address it to Dr. Gill, Gill, initial A. Thank you very much for referring Casey, who is pleasant, 29-year-old female with respect to possible connective tissue disease. In view of her current symptoms and abnormal ANA serology. Paragraph Casey has been experiencing joint pain, primarily in her knees. For the last few months, her knees are always more painful at night, and she would describe pain as throbbing or aching. It is associated with stiffness. She also has experienced arthralgias across PIP joints with no obvious swelling. She is normally very active person, but her activity level declined because of pain. She also had some achiness around her hips. Second of all, her level of energy declined. She is severely fatigued and has been waking up she has been sleeping sometimes more than 9 hours per day. Stop. It is not unusual for her to fall asleep in her coat when she comes back home. Stop. Over the last year or so, she had a frequent upper urinary tract infections with no clear explanation. She also developed sun-induced rash on her back and has been left with areas of hypo and hyperpigmentation. Stop. She has no history of fever or chills. She lost about 30 pounds since January of last year. Some of that weight loss has been intentional. She is non-smoker. She has no symptoms suggestive of either Raynaud's or Sjogren's. There is no history of thromboembolic complications, seizures, or psychosis. She menstruates regularly, being on BCP, and her periods are light. She never been pregnant. Stop. She suffers from migraine headaches and they respond to Advil. Stop. She is also known to have right bundle branch block and non-sustained ventricular tachycardia. She has been treated with beta blockers in the past, but she's avoiding certain triggers and that seemed to work for her. Paragraph. Current medications, BCP and Advil, PRN plus multiple supplements. Paragraph. Allergies, none. Paragraph. FHX, mother well, father OA, fraternal grandfather RA, one cousin AS. Paragraph. She is non-smoker and non-drinker. She had chest x-ray in October of last year and that has been normal. She also had echocardiogram done within the last year or two and this has been normal. Paragraph. P/E revealed erythema over both upper cheeks, crossing nose bridge and sparing nasolabial falls. Small, faint, hyper and hypopigmented patches over back and anterior chest. No telangiectasia or petechia, no thyroid enlargement or lymphadenopathy, normal heart sounds, irregular heart rate, lungs clear to auscultation. MSK exam revealed no tender or swollen joints. Paragraph. Blood work. Positive ANA 1/160. Speckled homo, normal CBC, CRP 0.2, ESR2, normal differential, creatinine 68, negative RF and anti-CCP. Paragraph. Impression. Casey presents with history of severe arthralgias, photosensitive rash, fatigue, and abnormal ANA serology. One has to consider possibility of connective tissue disease. She was referred for more in-depth blood work and microscopic urinalysis and will also have x-rays of hands, wrists and feet and knees done. She was placed on Advil 400 milligrams at bedtime. I will review her at 2 to 3 months' time to discuss in more detail diagnosis and further treatment. Stop. Thank you for referring Casey for consultation. Stop. Anna Ruszyńska.